The way you resolve DIC is supportive care, but you need to treat the underlying cause of the DIC. So, administer chemotherapy, so treat the malignancy. If they're septic, give the patient antibiotics. So treating the condition will resolve the DIC.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS. Today, we're talking with ONS member Leslie Smith, Oncology Clinical Specialist at the National Institutes of Health in Bethesda, Maryland, about disseminated intravascular coagulation. This episode is part of a series about oncologic emergencies. The previous episodes are linked in the episode notes. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Leslie. It's great to have you.
Thank you very much for asking me to participate in this podcast. I'm very honored.
So to start, disseminated intravascular coagulation, that's a mouthful, so we'll call it DIC from this point forward. Can you briefly explain what DIC is?
DIC is an oncologic emergency in which clotting and bleeding happen simultaneously. And the syndrome generally starts with excessive clotting. The clotting is caused by a substance we refer to as a procoagulant factor, which we can talk about a little further. The clotting continues without stopping due to the continued stimulation from the procoagulant factor of the clotting cascade. And so you know that when you have a clot, eventually your body wants to break up that clot, and it attempts to do so with various other factors. But what happens in response is that the procoagulant factor continues to stimulate clotting. The body's trying to break up all these clots that continue to form. And so you have clotting and bleeding going on at the same time due to this hyperclotting bleeding state that's occurring in the body.
So what is it that causes DIC to develop in cancer patients?
DIC usually in cancer can either be from the malignancy itself or sepsis. Those are the two most common reasons. But we can also see DIC happen in hyperinflammatory state. I think the best example of that are patients who have received CAR T cells and develop cytokine release syndrome. So a hyperinflammatory state can cause clotting and bleeding, so DIC to occur. In cancer patients, certain malignancies tend to be more prone to the development of DIC. The most well-known example is acute promyelocytic leukemia, which releases a procoagulant factor, as well as some gastric cancers, which secrete certain cytokines or procoagulant factors that stimulate the clotting cascade.
I see. So this seems somewhat obvious, but why exactly is DIC considered an oncologic emergency?
The patient, in the body's attempt to break up the clot, platelets are consumed during this process. And so as platelets are consumed, the platelet count drops. Now, for patients with APML or acute promyelocytic leukemia, they may already present with a low platelet count from the leukemia itself. Then the patient's platelets are consumed, fibrinogen, et cetera, is used up. The patient doesn't have an ability to prevent bleeding anymore because there's nothing left, because it's consumed by these clots that it's trying to degrade in the body. So, and in addition, you have the clotting. So clotting can result in end organ damage, kidney damage. The patient could have a stroke from the clots, a heart attack or an MI from all the clots. So you've got these two simultaneous processes going on. So that's why it's an oncologic emergency.
How does DIC initially present, and then how does it progress once a patient starts to develop that excessive clotting?
Generally, nurses will see excessive bruising on a patient, maybe large ecchymotic areas. Patients may have prolonged bleeding. So, if you're doing a venipuncture on the patient, it may take a while for the bleeding to stop from the venipuncture. Or if the patient has a central line placed, they may continue to have bleeding. So, that's generally how the patient presents. The patient may have petechiae on their legs or in their mouth, purpura in their mouth. And that's what the nurse will see is these unusual prolonged bleeding and then bruising that the patient may have. An example that I can think of when I was working at the bedside is we had a patient present who had 2 large retroperitoneal bruises. She didn't fall, she wasn't in an accident, and she said they just appeared one day. And this patient was a new diagnosis of APML. And so she was in DIC when she presented from the leukemia. That's an example of how the nurse can clue in to the patient may be in DIC.
After they notice that initial bruising that can't be explained or isn't attributable to something specific, what are the next steps when they start to develop clotting? Does that continue to progress and then eventually, as you mentioned, have end organ damage?
So the next step is really to look at the lab work. The nurse really wants to look at what is the patient's PT, PTT results. What are their platelets? What's the platelet count? What is the fibrinogen? The fibrinogen will generally be low. Fibrinogen is used to break up the clot, if you will. And then the D dimer. So the D dimer, if it is high, that is indicative of a clotting issue occurring. So the next step for the nurse would be to look for the labs or ask for an order. You can order a DIC panel in some institutions, but look at coagulation labs. And then really the care is supportive in these patients. DIC is not a disease in itself. It is a symptom of a disease. It's a syndrome, and it's indicative of another problem occurring.
I think you've touched on what I think is a challenge is that sometimes the initial symptoms are simply just that bruising, things that as nurses, we try to connect to other symptoms or other disease processes that might be going on, but really that could be the first clue that it's something more emergent. So that's a great tip to keep in mind when you see these bruising spots on patients, just always keeping that in the back of your mind. Is DIC only an acute issue or is there a chronic form of this? And what is the difference between those two?
There is a chronic form of it, and patients can live years for this. The difference between the acute and chronic, so the acute happens right away. The patient has a lot of bleeding and a lot of clotting occur all at once, but it requires treatment. So as I had said before, DIC is not a disease. It is a symptom of a disease. And you need to treat the disease in order to resolve the DIC. In the chronic form, patients who live maybe in a chronic inflammatory state, maybe from arthritis or whatever the process is, their coagulopathy will not be as severe as an acute form. They may have an elevated PT, PTT. Their platelets may be a little bit low. Their fibrinogen may be just a little bit low, but it's not life-threatening. And in an acute stage of acute DIC, it is life-threatening because they may have a severely elevated PT or PTT. Their platelets may be extremely low, below 50,000. They may have a very low fibrinogen, and it becomes a life-threatening issue. And so I think that we're headed this way, Jamie, but the way you resolve DIC is supportive care, but you need to treat the underlying cause of the DIC. So, administer chemotherapy, so treat the malignancy. If they're septic, give the patient antibiotics. So treating the condition will resolve the DIC.
Well, speaking of conditions, we've touched on this a couple of times, but just to be very clear about it. So which patients with cancer are at higher risk for DIC? And then maybe a follow-up question, what other conditions could potentially cause DIC? Because we know our patients don't always come to us just with a cancer diagnosis.
Patients who APML is the most common malignancy we see that causes DIC. And it's probably from some kind of enzyme or, something within the APML. Nobody's really sure that's stimulating the clotting. But also mucin producing tumors. So these would be gastric type tumors, but also ovarian and pancreatic cancers. The mucin that is produced drives the development of DIC, drives a clotting. Patients, as I mentioned before, who have received CAR T cells. So even in this COVID area, we've seen this with patients who have COVID as well, when they develop cytokine release syndrome as a result of if the CAR T or they have COVID, the virus, they can develop DIC from the virus or the CAR T cells, this hyperinflammatory state. And in addition, sepsis. So within sepsis, the bacteria that the patient is septic from damages the blood vessels. And when the blood vessels are damaged, there's this procoagulant factor released from the endothelium of the vasculature. And this is what will drive clotting. Conversely, as the body tries to break up the clots, you have this cycle that just continues to get more severe.
That's really interesting to just keep in mind and consider that it's not always going to be their cancer diagnosis in that disease state that's maybe fueling this. It could be those sort of other conditions that can come about because of either the cancer they have or the other diagnoses they're dealing with, or side effects and symptoms from the treatment they're getting, like sepsis and having neutropenia. So that just adds to the complexity of identifying this and working through this with patients. Is there anything that can be done to reduce a patient's risk for developing DIC?
For leukemias, APML, there's no screening for leukemia. So we can't really do anything about that. You could do screening. There's no really screening for gastric cancer unless you have a genetic mutation or genetic variant that may cause a person to be at risk for gastric cancer, for example. But if we are taking care of patients who have received CAR T cells, for example, we monitor. These nurses know to monitor for cytokine release syndrome. We're watching for fever. We're watching the CRP levels or the ferritin levels. We're watching for the cytokine release syndrome, and we're treating appropriately via tocilizumabs. Most institutions give toci, some institutions give steroids, preventing DIC that way. Patients who are at risk for developing sepsis, so your neutropenic or pancytopenic patient who's received chemotherapy or post-transplant, watching for signs of impending infection, sepsis, administering prophylactic antibiotics in certain populations of malignancy or post-transplant, or the nurse watching for fever or educating the patient, call us if you have a fever, or come back to the hospital, come to the ED if you have a fever. Those types of things can prevent DIC from occurring.
That's great information. And as I think through my own experiences, I primarily worked in the ambulatory setting in a clinic-based and coordination of care type environment. And so DIC always seemed to be, for me, something that was an inpatient thing. That was that kind of emergency. But as you've explained, and maybe there's more we can add to that, aside from the bleeding, we talked about sort of maybe mysterious bruising or fever, like you just mentioned. Are there any other very preliminary signs or symptoms of DIC that oncology nurses should monitor patients for, whether they're working with patients who are still at home and coming in for their appointments, or even for those patients that are already maybe admitted for other conditions?
I think it can be a little bit confusing for the nurse because, as you mentioned, Jamie, they're vague symptoms. So if you have a patient who maybe is thrombocytopenic, you could attribute, well, they have all this petechiae from their thrombocytopenia. It's difficult. That's why you need to really draw a lab. The nurse will need to ask for an order for the coagulation lab. So the PT-PTT, the fibrinogen, the D-dimer, the platelet count, because it is not just one lab or one sign or symptom that will diagnose DIC. There's no one thing that tells you that the patient has DIC. You need to look at all the lab work to make that determination. And then the patient too. Some patients may not have any bruising, may not have any outward signs of DIC, and it may just be picked up because you happen to look at the lab. So there's no one thing that's diagnostic of this. For the nurse, it can be confusing because we'll automatically think, oh, that patient platelets are 10. That's what all this is caused by. That may be part of the reason, but it's not necessarily the case.
Well, I think that's a great commentary on that because it isn't something that as nurses will be able to singularly say, oh, this is the problem, but it's more tucking that information in the back of your mind to say, wait a minute, I remember learning about DIC. Maybe this is a little suspicious, or maybe it doesn't add up with their symptoms they're having. Maybe I should advocate to explore this further, talking with the physician or the APP to understand, is there more we should be doing just to check all the boxes? So I think that's great advice of it's not going to be one single thing, but keep that information swirling in there so that maybe it will be something that you should explore further. I mean, that's our role as nurses, right, is to advocate for what needs to happen for our patients. Let's get down to what we do about it. So you've mentioned before, it's primarily symptom management. What are the roles and steps that nurses can take in managing or caring for patients that are experiencing DIC?
First of all, you're going to support the patient with transfusions. So they may be platelet transfusions, FFPs, which is fresh frozen plasma, or cryoprecipitate. And this will help in an attempt to normalize the labs or at least get the factors and the platelets back up. And then treating the disease. So if the patient has APML, giving the chemotherapy or whatever the cancer is that's driving the DIC, administering the chemotherapy. And then in addition, if the patient is infected or septic, administering the antibiotics. You know, we all have a standard that if the patient has febrile neutropenia, we administer antibiotics within 1 hour. We want to prevent sepsis. But if they're septic, that may require an ICU admission. And then in addition, if the reason is CAR-T, we want to administer TOCI or, depending upon the grade of the CRS, which is not really the purpose of this talk, but what is the antidote, but supporting the patient. But for the nurse, it's mostly transfusions. We're trying to normalize the lab values.
That's very helpful. And as you've mentioned before, the solution or the supportive care will also be driven by what's the underlying cause. And so it's not necessarily, aside from general transfusion support, as you mentioned, the real solution is supporting resolution of whatever the underlying cause could be. So that's great information to kind of keep in mind. It's kind of a dual approach. Well, what a complicated but important topic that we've covered. I think I've learned more about DIC, even though it's not something that I directly experienced in my practice. As we conclude our podcast, we like to always ask a few questions just to summarize what we've talked about. What are some common misconceptions about DIC?
So DIC, it's often thought, especially by patients or families, that once you start that chemotherapy or the antibiotics, that the DIC will go away. That is not true. The DIC, it can take days to weeks for the DIC to resolve itself. So it's not something that's going to happen overnight. The patient will need to continue to be supported. Patients and families and nurses think that it will resolve immediately, but it doesn't. It often can take days to weeks to resolve.
That also helps us understand the support we'll need to provide to those patients as it potentially lingers for some time. And so even though it is an emergency, it could be a chronic emergency, as we talked about earlier, that there is the longstanding form and it might take time. That's great for us to know. What's something about DIC that's not often discussed, but you wish people knew more about?
I think it's something that is not immediately thought about. So as I had mentioned before, nurses often think all of this is driven because of the pancytopenia of the patient. But, consider what is the diagnosis of your patient? If they have cancer, what kind of cancer do they have? And ask the question to yourself, could this patient be in DIC? Is there something more we should be doing or looking at? If your patient is septic and, you work in an ICU, generally patients have a whole battery of lab work ordered on a daily basis. But if coagulation labs are not ordered, should we be looking at those as well in order to administer maybe cryoprecipitate or FFPs? So I think that DIC tends to be something most people don't jump to as a syndrome that they think might be going on with the patient, especially in oncology where we're used to seeing patients with low platelets all the time.
I think that's very helpful to consider, and maybe is commonly seen for all nurses in oncology, depending on what types of patients and diagnoses that they're caring for or what part of the continuum they work in. But it is important, and as you said, to always keep that in the back of the mind is like, is this a possibility? Don't forget about it, even though it may not be common. It's always there. What additional training or education should oncology nurses seek out to better treat their patients for DIC?
There's a lot of good articles out there on DIC. In addition, one resource I always refer to is Up to Date. It's very medically focused, but it is a wealth of information about different conditions like that. So those are some resources. You can find a lot of information on DIC in the literature, in medical and nursing literature, but Up to Date is one resource I use quite a bit when I want to find out more about conditions like this.
Well, I feel like I have some homework to do on refreshing my memory of the clotting cascade. Do you have any final comments to share with us today?
Thank you very much for this podcast. And I do think it was valuable. DIC is something that is very complicated, and a lot of people don't want to think about it because the clotting cascade is a very complicated physiologic process that occurs. Thank you very much. And I think this is very valuable.
Well, I think you've provided lots of interesting thinking points of how we can integrate the possibility of DIC in our sort of differential when we're seeing patients with some of these symptoms that present. And as you mentioned, advocating for our patients. So if we as nurses have concern, asking that question, collaborating with our physicians and our advanced providers to understand, is this a possibility and should we pursue it further? So thank you so much, Leslie, for all the great information that you shared with us today.
Thank you, Jamie.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.